We are live now.
Yes. So, good afternoon, dear sir and ma'am. It's been great pleasure to welcome you all for this APA PG Masterclass on behalf of APA Vellore branch. So, today the session is about the respiratory disorders, a clinical perspective by final year MD postgraduate from CMC Vellore. And the specialist and moderators, Dr. Ramya ma'am and Dr. Richa Gupta ma'am from CMC. Over to you, Dr. Ramya ma'am, to take over the session and proceed for further discussion.
Good afternoon, everybody. Today we'll be talking on patient with a respiratory disorder. So today we have with us Dr. Richa Gupta. Ma'am is the head of respiratory medicine in CMC Vellore. She's got more than 2 decades of experience in respiratory medicine, is expert in bronchoscopy and thoracoscopy and many other procedures. So she will be moderating this session along with me. I'm Dr. Ramya from the Department of Medicine. And today the presenter will be Dr. Alcy, who's our final year postgraduates. So we'll start with the presentation and then we will stop the presentation in middle and discuss certain questions and issues.
Good afternoon to one and all. Today the system I'm going to discuss is respiratory. So I'll be presenting a 20-year-old lady from West Bengal who's a third year BA student, has presented with 2 months history of fever, 2 months history of cough, weight loss for 2 months, chest pain on the left side for 2 weeks, and breathlessness for 3 days. History of presenting complaint onto each symptom separately. Fever, she had it for past 2 months. It was high grade intermittent with evening rise of temperature, no chills or rigors or night sweats, and it resolves on taking paracetamol. Cough was again for 2 months with no expectoration. There was no seasonal, diurnal, or positional variation. There was no aggravating or relieving factors not associated with wheeze, no hemoptysis, or no URI symptoms at the onset of symptoms. Chest pain was recently onset for the past 2 weeks. She describes it as a sharp stabbing type of pain located in the left lower chest, below the nipple, as well as below the axilla. It was mild to moderate intensity. It was not associated with any radiation, nor associated with exertion. It was aggravated by deep inspiration as well as cough and relief on lying down. Breathlessness, it was the most recent symptom, which was for the past 3 days on exertion. Her prior MMRC was grade 1, and her effort tolerance for the past 3 days has decreased to 300 meters on level ground, being MMRC grade 3. There was no associated orthopnea or PND. In the background of all these symptoms, she also noticed to have loss of weight of about 9 kgs in the past 2 months with loss of appetite. She did not complain of any allergies, no history of any arthralgia, photosensitivity, alopecia, oral ulcers, or Zika symptoms. No history of having pets at home. No history of swelling of legs, reduced urine output, or facial puffiness. No history of abdominal distension or right up hypochondrial pain. No history of syncope or palpitations. No history of hoarseness of voice, regurgitation of food, difficulty swallowing. No history of any trauma. Going into the past history, she did not have any history of surgeries, any comorbidities, alternative medicine intake, or over-the-counter drugs intake. No history of any COVID illnesses in the past. She had received 2 doses of COVID vaccine. Family history, there was history of TB in her paternal grandfather. No history of malignancies in the family. Father is a smoker and an ethanol user. Currently, he is in a de-addiction center, and mother works as a housemaid and supports the family. Personal history, normal bowel and bladder habits, normal sleep-wake cycle, no history of any addictions or substance use, and she is a mixed diet consumer. Treatment history for the above mentioned symptoms, she was evaluated at a local center in March 2025. She was told to have fluid in the lung and was told to have TB and started on ATD. which she stopped after 1 week due to nausea and vomiting. So now summarizing my case, she is a 20-year-old lady with subacute onset cough with fever, pleuritic chest pain, dyspnea on exertion with constitutional symptoms in the background of exposure to tuberculosis. Now, the probable system involved that I consider is respiratory, anatomical localization, probably being a pleuroparenchymal more than pleura, according to the history I got. And pathology I consider is probably infective more than a neoplastic or an autoimmune. And etiology probably being TB more than a malignancy or a CTD. Now, why did my for and against for the diagnosis that I have put up tuberculosis, because she has history of TB exposure. It is a subacute course of illness, constitutional symptoms. She has cough, pleuritic pain, and fever. Against is dry cough, because since I'm considering a pleuroparenchymal pathology, I would expect a cough with expectoration rather than a dry cough. However, if it is pleural involvement, dry cough can be the symptom. Malignancy, again, it is a subprimary lung malignancy. Again, it is a subacute onset with constitutional symptoms. There is history of passive smoking and a pleuroparenchymal involvement. However, she does not belong to a age group that is that classically present with a malignancy. Third thing which I considered in the diagnosis was a connective tissue disorder like a MCTD, systemic sclerosis. For my diagnosis would be she is a female patient, again pleuritic pain and constitutional symptoms. However, against this, because of the systemic features like arthralgia, rash, oral ulcers were absent.
So you've completed your history, Dr. Alsi?
Yes.
What is your differential now? If you have to put it at differential 1, differential 2, how do you put it up like that?
Ma'am, at the end of my history, my top differential is still is going to be an infective etiology with the background history and exposure of TB, again with the classical symptoms of fever and constitutional symptoms with cough, which is going on for a subacute period of time, more than about 2 months. I still put as TB as my primary differential. However, because of significant weight loss of 2 kgs, which is profound, 9 kgs, I would still consider malignancy. And third would be CTD, connective tissue disorders, because of again subacute onset, as well as she being a female, young female, is likely host for a.
But she doesn't give any history suggestive of any CTD.
Yeah, she does not.
Right. And what malignancy, if you are looking at, if at all, we are looking of malignancy, what is the one which you will think? Because in your differential, you have such primary lung malignancy. So you are looking for primary lung malignancy, or it could be something else involving the respiratory system.
It could be a secondary metastasis to lung, like a breast malignancy metastasis to lung. Primary per se.
No, I'm looking at whether it could be something else rather than primary lung malignancy. Secondary, we are talking about again breast there are no symptoms, right? There is no symptoms, so I don't think we should even look into that. But because she is young and there is history of 9 kg weight loss in 2 months, which still can be because of TB, but is there something else in a young patient you would like to think? Chest pain is there, breathlessness is there, cough which is dry. What other system could be involved is what I'm looking at. Pleura, yes, because pleuritic chest pain is there. What is the other thing which can be there in a young patient?
Interstitial diseases or
No. Interstitial lung disease, certainly no. You should have at least a history of more than 3 months.
indolent lymphomas.
Yes. There could be a possibility. Dry cough is there, weight loss is there, fever is there, OP symptoms are there, patient. And then patient is having pleuritic chest pain, breathlessness on exertion, right? So is it something which is mediastinal or some, say, lymphoma is there, which is now patient is presenting to you because there is an effusion? Because history they are saying is water in the lung. So whether the Pleural effusion can be there in lymphomas as well. So primary lung malignancy will not be the differential, what I wanted to say. But malignancy per se, if you are looking, then yes, lymphoma is one of the differentials.
Thank you, Dr. Richa. Can we go back to your history, I'll say. So I would like to ask you a few questions. Okay. So why do you think this is pleural chest pain and not cardiac chest pain?
So, ma'am, pleural chest pain. First thing is pleural chest pain is usually it's a character of the chest pain usually is a sharp stabbing type of chest pain, whereas the characteristic of a cardiac chest pain is more of a heaviness, compressing type of pain. Then the area, cardiac chest pain is usually retrosternal, whereas the pleuritic chest pain is more lateralized to the sides. And onset of chest pain, pleuritic is usually a sudden onset chest pain, and cardiac could be insidious, like over 2 to 3 days. And the cardiac chest pain usually comes down on taking rest or on nitrates, whereas pleuritic chest pain usually is relieved by lying down on the side effects. Same side of
Not radiating, you have said, which is a very
classical.
classic of cardiac pain if you are looking at.
And there are no associated features like vomiting and sweating and all. Going on to your next, the same slide only, next symptom, breathlessness. So what do you think of this breathlessness? So is it sudden onset or it is over hours, days, months, years? What do you think of this? And for each of this, can you offer some differential diagnosis so that we can look at how to approach a person with respiratory problem?
So her breathlessness is insidious onset. Over 3 days, she has developed it. So, so a person with a sudden onset breathlessness, we will probably think of a cardiac etiology. Second,
What respiratory etiology can cause sudden onset breathlessness?
so sudden onset breathless tension pneumothorax, then pulmonary embolism, then the COPD, asthma with sudden onset of symptoms can have, but they are unlikely. They usually have a
Exacerbation of underlying airway disease can be acute.
And one more, in children or elderly, what is that? Sudden onset breathlessness.
group larynx, aspiration, foreign body aspiration.
So foreign body aspiration. So we know this is not sudden onset breathlessness. It has occurred over days. So for that, can you give you some differential diagnosis?
So it could be for a insidious onset would be like an infection causing a parenchymal involvement or a pleural effusion, like the infection further causing a pleural effusion can cause insidious onset breathlessness.
What else? Anything? Because you mentioned that below, no?
Cardiac.
Cardiac causes. So
If
left
there-
ventricular failure can cause. Those also can occur insidiously. Anything which occurs over years, which we were talking about, which takes years to occur.
Eventually, if they continue to have a lung volume loss, they can have fibrosis.
Yeah, so interstitial lung disease and
Chronic breathlessness or chronic symptoms of breathlessness is interstitial lung disease and COPD, isn't it? The stable COPD they continue to have, or
moving on. Yeah, BT sequelae with the destroyed lung. So they go on to develop breathlessness over years. Thank you, ma'am. So looking at cough. So if somebody has dry cough, where will you localize it in the lung?
So dry cough is usually we can localize in the pleura versus interstitium usually. If it is in the airway or in the lung, it's usually a productive cough.
So if it is in the airway and like a COPD or asthma, what kind of sputum will you get? Expectorate? Is it mucoid or mucopurulent?
It is usually mucoid.
It's
and
mucoid.
Parenchymal, it can be suppurative, so it's usually mucopurulent.
Okay. So So you have answered most of the questions well. Looking at hemoptysis, so what is false hemoptysis and what is spurious hemoptysis? Any idea? Something to do with the localization in the airway itself. Spurious is?
The air. Spurious will be the parenchymal.
Spurious will be in the upper part of the airway. Upper airway. So false hemoptysis is when the sputum looks red, but it is basically not hemoptysis. So those are the things we need to think about. So I would ask you another googly. So what is trepopnea? Do you have any idea? And did you ask for it in your patient to identify which side the disease is in?
Lying on one side causing breathlessness, but I didn't ask.
What is it very pathognomic of?
The effusion. Sure. So going on to my examination findings. On examination, she was comfortable, conscious, oriented to time, place, and person, not in any form of distress, was adequately hydrated and moderately built. Height was 145 centimeter, weight was 45 kg with BMI of 20.5 kg per meter square. Vital signs, pulse rate was 78, regular rhythm, normal character, no radioradial or radiofemoral delay. BP was 100 by 60, measured on the right brachial, sitting up position. Respiratory rate was 22, thoraco-abdominal pattern with saturation of 99% on room air and temperature of 99.3. There was no elevated JVP, pallor was there. There was no icterus cyanosis, clubbing, lymphadenopathy, edema, no external markers of malignancy, external markers of TB, Horner syndrome, or sarcoidosis. So going on to the systemic examination, I'll start off with inspection first of the upper respiratory tract. Nasal septum was not deviated, no polyps, no tonsillar enlargement, good oral hygiene, no halitosis, no postnatal drip. Lower respiratory tract symptoms, lower respiratory tract inspection. Chest wall appears symmetrical, shape was flat, there was no costochondral bending. Reduced movement on the left side with inspiration was noted. There was no scars, intercostal fullness, indrawing, crowding of ribs or discharging the sinuses. Tracheal position appeared to be shifted to the right side. Apical impulse was not visualized. There was no drooping of shoulders. No supraclavicular and IC hallowing, no Harrison sulcus. Palpation on palpation there was no chest wall tenderness or warmth. Tracheal position was deviated to the right side. Trial sign was negative, so there was no prominent right lateral border of the sternocleidomastoid, which is why I have mentioned trial sign negative. However, on examination, the trachea seems to be deviated to the right side. Apical impulse, it was felt in the fourth intercostal space in the mid-clavicular line. Chest circumference was 40 centimeter, transverse was 24, hemithorax was right side was 17.5 and left was 16.5. Ratio on the right side was 1.37 and left was 1.45. Spinocapular distance on the right side was 10, left side was 9. Spinoacromial, right side was 21 and left was 20. Chest movement by palpation was reduced on the left side. Chest expansion on the right side was 0.75 and left side was 0.25. There was no intercostal tenderness. Tactile fremitus, in all lung areas, it was absent. Vocal fremitus on mammary was absent on both sides. Infraaxillary was absent on both sides. Interscapular and infrax was absent on the left side. And infrascapular was absent on both sides. Percussion, positive findings. Infrascapular, there was bilaterally stony dullness. And on the left side, interscapular as well as infraaxillary had stony dullness. Drop space was resonant and straight line dullness was absent. Auscultation, breath sounds, only vesicular breath sounds were heard in the areas where the breath sounds were heard, and there was no bronchial breath sounds appreciated. So individual lung areas on auscultation had reduced breath sounds on the infraaxillary on the left side and interscapular on the left side, and bilateral infrascapular were reduced. Vocal fremitus was in line with the vocal resonance, sorry. as same as the vocal fremitus, where infraaxillary it was reduced on both sides, interscapular was reduced on left side, and infrascapular was reduced on both sides. There was no added sounds. There was no bronchophony, egophony, or whispering pectoralogy. Other system examination, CVS, there was no, the other system examination was unremarkable. CVS S1 and S2 was heard. There was no murmurs. For abdominal examination was soft, non-tender, no free fluid or any palpable masses felt. And CNS examination, there was no focal neurological deficits. So at the end of the examination, my final diagnosis, I would like to put as bilateral pleural disease. And pathology being effusion, and etiology tubercular more than malignancy or CTD. Why pleural FI? I said a pleural disease because on examination, at the end of examination, I did not hear any bronchial breathing, no wheeze, no crepitations. It was purely reduced breath sounds, which is why I have put as pleural disease and not pleuroparenchymal at the end. Effusion, because again it was reduced blood sound, stony dullness, which is suggestive of effusion. Etiology is again back from the history. Nothing in the examination contributed specifically for TB.
No. Um, no, examination is okay. We'll go to the respiratory system examination. So vocal fremitus. So what I wanted to say is tactile and vocal usually, when we talk about tactile and vocal fremitus, it usually corresponds to each other.
Oh.
That was what I want to meant. And we say either it is equal or absent, right? So this absent in all areas probably may not be right. Maybe you get confused or this thing. So both usually align together. That is one thing. Then shall we go to the other? Now, drop space is a straight line dullness. So straight line dullness is the immediate shifting dullness we do. Whenever, did you do a, what do we say?
Delayed. I only did
Delayed.
that.
You didn't do that. What does that helps you to make out how useful it is?
Delayed is how is it different from straight line? And delayed is straight line is both can differentiate hydropneumothorax.
Right.
Whereas delayed, if it is a loculated collection, then it takes some time to settle. So it does help us to differentiate whether it is a just
Right.
a hydropneumothorax or a loculated.
No. So straight line dullness, if it is there, it means that most likely it is hydropneumothorax. And then you will do coin percussion test and all those things. Okay. Shifting dullness, when we talk about, is it immediate shifting dullness or it is delayed shifting dullness? When it is immediate shifting dullness, which favors more towards hydropneumothorax. Delayed, it will tell you about whether the fluid is free flowing or it is loculated. That will give you an idea, right? So here we are having a stony dullness. So stony dullness note is very much pathognomonic of pleural effusion. If you find it is pleural effusion, it cannot be anything else. What are the differentials if you have only dull note? If suppose there is dull note on percussion, what are the differentials?
Dullness can be consolidation,
Right.
empyema.
Okay.
Vision.
Empyema may again you will have
Drop
stony
sound
dull
dullness.
only. Collapsed lung, you can have dull. Mass, you can have a dull note, right? So stony dull note, what is the difference when we do a percussion? How do you say that this is stony dull and this is
high-pitched flat sound as you percuss on top of a marble stone.
and you feel a pain over your plexus, है ना? That is how you differentiate. So when it comes as stony dull, it is pleural effusion. There is no doubt about it. We want to now say, because in your history, it should come whether it is loculated or not loculated. That you will confront with presence of delayed shifting dullness or not. That's one thing. Now, based on this alone, how would you say whether it is mild, moderate, or large effusion? Based on your examination, are you able to say?
It is in
You can say.
a number of areas,
Yes.
areas of stony dullness. How many areas have?
We also look into the surface marking of the lung. So, anyways, based on this, you can say it is only localized in the infrascapular, that is posterior recess probably. So you have bilateral pleural effusion, left more than right. Left is most likely moderate and right is minimal or small effusion, if you would say. I mean, these are all those words which are very subjective, but depending on the areas involved, you can still say that it is a small and this one is moderate to large effusion, I would say. Did you have this? Okay, we didn't do that. We have to see the level when you do the percussion, right? Ellie's curve, did you do that?
No.
We didn't do that. So that will also give you an idea how big the effusion is. So on a, how do we do it is on a chest X-ray when we say if it is half of the chest is involved, it is considered as moderate. If it is up till second second rib, it is considered as large. And if the dullness is present up to the clavicle, it is considered as massive effusion, or you have a shift of the mediastinum to the other side, right? So if you would have done a dullness to find out where is all the localization, which is the highest point of dullness in your this thing, you would have drawn a line and you would have been able to find out whether it is large effusion or moderate effusion.
We'll go back to the exam. Before, okay. Oh, okay. We'll go to the next slide. So why did you look for halitosis, Dr. Alsey? Towards what respiratory diseases it gives a clue to?
Halitosis is if it's infective etiology like empyema and all, we can have.
Infective etiology of the lung and the airways. So what are those called? Infective etiology, a suppurative parenchymal disease.
What is that? All of the examples.
If there is an abscess.
Lung abscess. Very good. And then if there's suppuration in the airway, what do we call it? It's associated with clubbing. Yeah, bronchiectasis. So you have done a very good examination. So you're able to say halitosis is seen in bronchiectasis and lung abscess. Why did you look for postnasal drip? Why did you look for? In your history, you have something, so that's why you have looked for. To explain the. Correct, you're right. To explain the dry cough. So that is why. And why is good oral hygiene important in somebody with a respiratory problem? What does poor oral hygiene predispose people to?
They can have abscess.
Yes, they can develop pneumonias, aspiration pneumonias. Very
Which
good.
can go into abscess, which can produce halitosis.
Yeah, so which can also produce halitosis. So you have done most of the respiratory tract examinations. Yes. Next slide, please. So, did you look for kyphoscoliosis, or you want to demonstrate kyphoscoliosis with these distances?
So these distances will give an idea of kyphoscoliosis. The patient did not have it. So when there is the spinoscapular and spinoacromial diseases, have one is for this kyphoscoliosis, and second one to see if there is a lung volume mass or a drooping of shoulders. So all the values were both sides were almost 1 centimeter difference is not that significant.
So that
Apical impulse. Apical impulse is fourth intercostal space in mid-clavicular line.
Yes.
Normal or abnormal?
It is usually it is the fifth intercostal space, 1 centimeter medial to the midclavicular line.
Mhm.
But for her, I felt it was in the fourth intercostal space.
You were able to.
It was difficult to localize the pulse. So I have to put her in the left lateral position and then locate.
Okay. With the effusion, it becomes difficult actually. There might be a shift. So, other thing was there. I forgot. You haven't looked into the right heart border? Did you percuss the right heart border?
I had podcast, ma'am, but I did not mention
You didn't
it. Yeah, I had
mention.
talked
Okay.
about this.
It is important, especially in a patients with effusion. Again, it will give you an idea how large the effusion is. So if you're able to percuss the right heart border and you are able to say there is a shift of the lower mediastinum, upper it looks like because the tracheal shift is there, right? Then we know that this is large effusion or massive effusion.
So what else should you have percussed on the right side, Elsie?
Tidal percussion.
Tidal percussion.
So I had done it tidal percussion. So that was tidal percussion was actually positive, like it was two intercostal below was actually dull.
I'll
But
interrupt on that because once you have dull percussion on examination, then tidal percussion should not be done, because you're having already dull. So that will not give you, and you are having in both the bases, lower zones, you are having dull note. So that is why I only asked her.
Okay. Next. So based on this examination findings, which part of the lung areas do you think is involved? Which
so
lobes are involved?
So, according to my examination, I think it is on the left side, the lower and the middle lobes are involved. Areas are involved.
We got on the wrong side. This is pleural effusion. Lobes doesn't come, but it looks like mid and lower zones of the chest.
So in a patient with pleural effusion, will you get bronchial breath sounds?
You can still get bronchial breath sounds.
And how? If you have a large effusion and the lung is collapsed, it acts like a consolidated lung. And over the top of that, the pleural effusion, you can sometimes hear bronchial breath sound.
So you should look for it in your examination. That is the point I'm trying to make. Okay. Move on next slide. Okay.
Okay. How will you proceed now in this
So,
patient?
so I would like to definitely do a complete blood count, then chest X-ray to see if it's effusion plus or minus consolidation, do a pleural fluid analysis to find out whether exudative.
There are no findings of consolidation, right?
Yeah.
So be stick to what your examination findings are. You have examination findings suggestive of bilateral effusion, left more than right.
So, chest X-ray for the effusion, pleural fluid analysis to find out whether exudative or transudative, and again expert PCR since my first differential is TB, and pleural in case if expert TB comes negative and we want a definite diagnosis, I would like to go ahead with the pleural biopsy since pleura is the primary area of pathology. And
Okay,
definitely LFT, RFT, and
sure. Bilateral effusion, young female. Do you still want to stick to TB?
it is unlikely for TB to cause. TB is not one of the first reason that causes bilateral pleural effusion.
Mhm.
But since there is underlying exposure and other associated symptoms, I would still keep TB as my first.
Do you want to consider lymphoma or something else at this point of time?
Yeah, ma'am. In the background of significant loss of weight and loss of appetite, if TB comes negative, then definitely I would like to.
But at the same time, you haven't got any examination findings suggestive of mediastinum. What are one or two signs which will say that mediastinum in your examination?
If you have mediastinal tenderness, I mean the tenderness of the sternum, lymphadenopathy, or a mediastinal.
You do the sternum percussion also you do, which is not done. That will also show if there is widening of the mediastinum on examination. One thing, then
Some sign you look for. over the face. When you lift the arms.
Pump button.
Anything else you can do?
D-spine sign, auscultate. Huh? What is that? Oh, okay. All right. So, so now lots of different, huh? So basically, all right, no, but no. I got this thing what I was asking. So you would do all these things. What are the lights criteria to distinguish between transudate and exudative?
Lights criteria.
Mhm.
If the LDH by pleural fluid LDH by serum LDH more than 0.5 or pleural fluid protein by pleural serum protein more than 0.6.
It's
Sorry,
opposite. Protein more than 0.5 and PS ratio of LDH more than 0.6. And which is the third criteria?
Then
Absolute value of LDH more than 1000 or 2/3 of the upper limit. है ना? That is one thing. Based on one thing is you want to calculate when you want to find out whether this is transudative or exudative. Can based on biochemical parameter on the pleural fluid, you can find out whether this goes more in favor of tuberculosis or not. I'm just asking few of the any biochemical parameters.
ADA.
ADA, very good. ADA more than more than 40. Between 40 to 70, one thing. What else it could be there? Any other thing? You do a pleural fluid differential counts.
If it is a lymphocytic
Lymphocytic predominant, it favors most towards tuberculosis or even malignancy. Anything you have heard about Allen ratio? Lymphocytic to neutrophil ratio? More than 0.75 favors towards TB. But again, those are all, age-old things. Even early TB pleural effusion can present with neutrophilic effusion rather than lymphocytic. Okay. What is the, so one thing is ADA is a very good marker. We can differentiate provided it is fitting into the clinical history and the age group which you are saying it looks like. If the ADA is very high, what does it favors? If it is very high, 100, 150, no, favors more towards malignancy. Lymphomas, you can have very, very high ADAs. Even in empymas, you can have if you're sending. You want to send expert TB PCR in pleural fluid. Less than?
less than 60.
No. How much? What is the yield? If you want to send, right? You want to send pleural fluid expert TB PCR. What is the yield? How much? Any guesses? Any guesses?
Some numbers.
Say-
Looking for numbers 10, 20, 30, something.
No
20.
idea. No, 20 is a very big number if we get it. It is less than 10%. It is around 5 to 6% only. So that is why expert TB PCR in pleural fluid is not recommended by the RNTC, our DOTS. That is not done. But expert TB PCR has good yield in other extraparenchymal samples, for that matter, CSF fluid and all. It has good yield, but not in pleural fluid. Okay, so
Um, so can you tell me a bit about the lymphatic drainage of the lung and the pleura? What do you know about it? So where will you look for lymph nodes?
Usually it's in the inframammary axillary.
Yeah, axilla, both the axilla will drain which part of which pleura? Parietal, visceral pleura? Okay, it's the parietal pleura. The right lung and the lower lobe of left lung is drained to the which node? Drains to the right supraclavicular node. And the left lingula and the upper lobe drains to the left supraclavicular node. So these are the nodes of clinical importance you should look for. Do you think so? If somebody has bilateral pleural effusions, did you look for polyserositis in this person? Mm.
Parasitis, edema, which was
If she had polyserositis, what will be other differential diagnosis you'd like to offer?
polyserositis is one I would think of autoimmune causes like SLE. And other thing would be a systemic illness other than like renal disease, nephrotic syndrome, or renal liver disease. Less likely, but
So they are all not polyserositis. No, polyserositis is very specific. That means there's inflammation of the serous surfaces. So CLD and nephrotic syndrome cause just hypervolemia or volume overload.
The other possibility, those clinically symptoms are not there. Bilateral pleural effusion, still you wanted to consider that this could be more likely TB. What else you would like to do in this patient which you haven't mentioned here? Bilateral pleural effusion and TB is my differential, first differential. What test? Yes, what test you would like to do? No, bronchoscopy not for pleural diseases, certainly. No, that will come later, right?
initial
What is initial? Like you have done all these, you have planned these tests, no? But if a patient has bilateral pleural effusion and I'm suspecting that most likely this is TB, I would like to do one more test for this patient, young patient. 2 months history is there. You want to do an echo or something like that to look for constrictive pericarditis? That is one of bilateral effusion when it comes, है ना?
With your permission, can I ask you questions now?
Sure, Dr. Anita.
Yes. Dr. Elsie, that was a good presentation. Can you tell me what are the causes for left-sided pleural effusion?
Ma'am, infections, left-sided lung infections, left-sided heart failure can cause the ascites sometimes can, pancreatic ascites and can sometimes cause a left-sided pleural effusion. Esophageal rupture can cause.
Okay. So what is meant by trial sign?
Ma'am, trial sign is the prominence of the lateral border of sternocleidomastoid due to shift of trachea to the side. So
Sternocleidomastoid or any specific head?
a lateral head, clavicular head of the.
Okay. So any idea about the D-SPN sign?
I am not.
Any idea about it? At least related to what? D-SPN sign. Suppose in your case some malignancy is the etiology, because you told some malignancy also cause for pleural effusion. If you're suspecting malignancy, how do you want to rule out? So I actually, Dr. Ramya ma'am also already asked the causes of bronchial breath sounds in pleural effusion. It is also one of the cause. So above the level of effusion because of the passive collapse, and also backs over the spinous process below the D4 level. You will hear the bronchial breath sounds because of the subcarinal mass compressing the trachea. Okay, the sound will be transmitted towards the spinous process. Okay, can you brief about the BPAL regimen? BPAL regimen, any idea about it?
It's pediculin regimen. Okay. Bedaquiline, proteomide, linezolide.
Yeah, almost right.
Bedaquiline, linezolid, proteonamide, and
Pretonamide. It's not proteonamide. Pretonamide. Okay.
protonamide.
Bedaquiline, pretonamide, and linezolid and moxifloxacin for the drug-resistant tuberculosis. MDR-TB is a short course regimen and long course regimen is also there. Okay. Okay. Thank you.
Any questions from anybody in the audience? On Zoom, anybody wants to ask questions?
Fifth expert, we said is very low need is there, that is negative. Pleural fluid analysis showed that it is lymphocytic oxidative diffusion, and ADA is around 39 or 35. How are you going to proceed with this test, with this patient now? Cytology is negative, and cultures, routine cultures are also negative.
We can go ahead and do a pleural biopsy.
What are the different ways of doing pleural biopsy?
Thoracoscope.
One thing is thoracoscopy, the other thing is you can do ultrasound guided or CT guided closed pleural biopsy. Is there any difference between image guided pleural biopsy versus thoracoscopic biopsy?
The
Well,
yield will be better than this thoracoscopy.
So when we talk about TB per se, there is no difference. It's around 92% with closed pleural biopsy, or even you don't do it image also because there is diffuse involvement in TB, whereas it is 96% with thoracoscopy. When it comes to malignancy, there is a huge difference. Malignancy is more localized disease, more posteriorly placed. So image guided pleural biopsy versus thoracoscopic guided pleural biopsy, thoracoscopy has much better. 70% versus 95%. What did you do in this patient?
So in this patient, ma'am, so his total counts were 7,500 with neutrophilic predominance. Pleural fluid analysis was suggestive of exudative effusion. Expert TB PCR has come in the, we had sent a sputum which was negative. Pleural fluid was also negative, whereas from the pleural tissue, it was positive.
Oh, biopsy was done, which was positive. How do you see it?
Like since it is a rifampicin positive, we will start on ATP. We'll do a baseline creatinine and LFT to make sure that we can start the full dose. Yes, in case if she develops.
What are the baseline tests as per dots you're supposed to do more than creatinine and LFT?
Other things which you would like to do. According to dots.
According to dots. So what underlying diseases would you look for in her? Because she's a young lady with bilateral pleural effusion due to tuberculosis. So what would you look? Retrovirus and? She's lost weight also, no? What is the most common cause of weight loss in India? Uncontrolled? Diabetes. So we look for retrovirus positive and diabetes. So as per dots, these are the first baseline tests you're supposed to do. Okay. And you'd like to do a LFT. Okay. What is a duration of regimen do you plan for her?
6
Elsie? Elsie?
Yes. Yes, ma'am.
For a case of acute febrile illness with bilateral pleural effusion, what are the differential diagnosis?
Dengue is one differential, ma'am.
Okay.
Then
The scub typhus and leptospirosis, how the lung will get involved?
they can have ARTS.
In malaria?
Malaria can also have ARDS, ma'am. A lung can be involved.
What is a phantom tumor?
The the fluid in the it's a fluid in the minor fissure, ma'am.
Okay, so it disappears after the diuretic therapy.
Diagnostic.
Okay.
Just wanted to make a remark about the testing. We did chest X-ray, then you said that we'll go ahead and do the aspiration. But in all cases of pleural effusion, we should be doing an lung ultrasound. So that also can give us a lot of added information. What can you see in TB on lung ultrasounds? What are the few findings you may be able to identify there?
Anechoic collection septations.
Yes. We'll be able to see septations. We'll be able to appreciate pleural nodularities also at times, both on the costal as well as the diaphragmatic pleura. And one more question is medical thoracoscopy. So we know it has very good yield in TB. What is the typical finding that you will see on a tubercular, case, TB pleuritis? What do you see? Classic finding.
Whitish blood.
Appearance. It's a pathognomic sign for TB.
Sago-green colitis, like the sago-green, small nodules will be there throughout the pleura. Very characteristic. If you see that, this is TB. Also, what Matthew has added, very valuable thing, that all pleural procedures should be done under guidance only, and it will also give you, I think, if the adhesions or these things are present, you know that this is exudative fluid, this is not transudative, so it can give you an idea. So one last question from my side, if you would like to answer. This is a patient with bilateral pleural effusion. Most of the times we say that the etiology would be same for whatever the effusion is. Is there any condition where etiology can be because of different causes? And that is a syndrome. So right effusion is because of one condition and left effusion is because of other etiology. That is called as that's a brownie point question. That will give you A plus. Conter-Renes syndrome, where very rare condition where you have bilateral effusion because of different etiologies. Most of the time, or majority, it is the same etiology which is causing. But very well presented and worked up nicely.
Since we have no further questions, we will conclude the session, and I would like to thank Dr. Richa and Dr. Halsey for a very good presentation, and thanks to everybody who's joined us live and online for sharing the session with us. Thank you.
Thank you so much, CMC Medicine Department team and then the specialist. And very good presentation, Dr. Elsie. Thank you, everyone. We can end the session. Hexicon, we can end the session.